So, Dr. Mark Gordon, welcome, and thank you very much for joining me today. You're the Director of Millennium Health Centers, and you've been developing the fields of interventional endocrinology and neuroendocrinology for a really long period. You've been really making it accessible to people as well, which is what's so important. Having been on the Joe Rogan show, you've done TED Talks and numerous audio recordings and YouTube videos as well. You've been working with people with depression, anxiety, bipolar, OCD, even dementia and Parkinson's and post-concussive syndromes as well. And you've had a real focus on traumatic brain injuries, helping countless veterans that have suffered from blast injuries. Can you start off by telling us a little bit about that, please?
Absolutely, and thank you very much for having me. We're 6,000 miles away, but it's a pleasure to be there. In fact, the UK was one of my favorite countries to visit when I was in my youth, having spent 3 months there back in 1971. So it was great.
It's a pretty good hunk of rock over here.
I love the history. I love the history is what it's about. Anyway, the area that I work in is called neuroendocrinology. And what the science is relative to neuroendocrinology is how the hormones of our brain and body influence our neurological circuitry. And that neurological circuitry is, our cognition, our memory, our recall, our personality, our behavior, our emotional reactivity, and so forth, as well as our ability to heal. Because we're finding that a lot of our hormones are not just about gender or sex or reproduction, but they're all about how to make the body complete and function optimally. So the area of neuroendocrinology is what I work in. And through that venue, came across the relationship between a multitude of injuries that occur to our body, whether or not it is pure stress or blast wave, as in our military, or a car accident, or being hit on the head through an assault, or a slip and fall, or certain medication, that it alters the chemistry of the brain, which leads to problems with emotional presentation.
So that's really interesting there, what you've just said there. So you talked about blast injuries, and I guess you're encapsulating even rapid deceleration injuries there. But you've also mentioned stress. So, yes. I mean, there obviously one can cause the other, obviously. But, talk to me about that relationship, because really when you think about neural injury, certainly as clinicians, I think a lot of us would be sitting there thinking a physical injury. But tell me about
Yeah. Well, this is where I come in conflict with the diagnosis of post-traumatic stress disorder, or PTSD or PTS, which I really don't believe in, understanding the neuroimmunochemistry of the brain. So what happens is, regardless of the causation, there's initiation of inflammation in the brain. And that's inflammation in the brain destroys all the chemical pathways and inhibits a lot of the neurological communication between lobes. So the question is, how does stress create inflammation? Well, it turns out that under stress, the stress hormone called cortisol goes up. And when cortisol goes up, a nerve cell production of a chemical called fractalkine goes down. And fractalkine is what keeps the immune cells, called the microglia in the brain, in a sedentary state where they're not dumping pro-inflammatory cytokines. The same cytokines that caused people dying from COVID, cytokine storm. Well, the same thing happens in the brain under stress and after physical trauma. So what happens is these microglia are activated. And when they activate, they dump chemistry that's very inflammatory into the brain, and it shuts down some major pathways. An example would be one of the free radicals that's generated from stress and or physical trauma is called peroxynitrite. And peroxynitrite inhibits two very important enzymes in the brain, L-tryptophan hydroxylase and L-tryptophan decarboxylase. What they do is the key. They convert L-tryptophan, a common amino acid found in turkey and other nutrients. It converts to serotonin. So you lose the enzyme and you lose serotonin. And then the carboxylase converts serotonin to melatonin. So you depression from one, insomnia from the other, and from the insomnia, you end up getting sleep deprivation syndrome, which causes all those emotional problems. That's how stress plays a role in creating these personality changes, these chemical processes. In the true definition of PTSD, you have no physical trauma. All you have is this chronic stress, whether or not you're in the battlefield of Afghanistan, being exposed to life-threatening scenarios. That causes cortisol to go up, fractalkine to go down, inflammation to go up, and that inflammation is like pouring acid on your tissue in the brain, and it starts leaching away, damaging areas of the brain. But one of the fallacies I believe in PTSD is none of us has not had a head trauma. None of us has not had some form of, we call it subconcussive trauma. Subconcussive versus concussive trauma. In subconcussive, you get a hit, subconcussive brain trauma, you get a hit, no symptoms immediately. And over the course of time, you have more and more of these subconcussives that become cumulative until they reach a certain level, and then you become symptomatic. With a concussive strike, you knock to the ground or not knock to the ground, they say you're in the States that you're rung your bell. You know, it's like in soccer in the UK. You've got Manchester, and they're heading the ball. And when they head the ball, each one of those headings is a subconcussive trauma. That's why here in the United States, they've made it illegal for less than 13, 12, whatever the age is, for heading the ball. And I understand in other countries that do soccer that they're restricting the heading of the ball certain ages, because that's a subconcussive trauma that has no immediate symptoms but will develop symptoms.
Yeah. Okay. So I mean, really, I guess what you're saying is that actually our management historically of head injuries, and I think even in the UK that's changing, especially with you see massive changes in rugby and in the regulations and the rules for rugby and things, because of the phenomenal impact that was having. And we're seeing more and more some of these guys that are really suffering with significant long-lasting symptoms from their repetitive head injuries and things.
Right.
But it's still really interesting that you're taking the sort of potential emotional stressors. So is it a similar thing? Is there something slightly different happening with the rapid deceleration injuries, with the physical injuries, or is it all just looking down the same process?
It's all the same. The only difference is when you have a physical impact of the skull, what happens is something called mechanotransduction, where just from the vibration of the neurons and the cells against each other elicits activation of the microglia, or the micro trauma might lead to microvascular bleeding. So you might have a little bit of bleeding occur, a contusion of the brain, and all these processes release inflammatory or cell signaling chemistry, and also upregulates the mitochondria, which are the energy powerhouses of the cells. And when under a challenge, whether or not it's a trauma, stress, bacteria, virus, or a mold, the body starts producing more energy to fight it off, ATP. And in the process of making ATP, you make something called reactive oxygen species, which is a free radical that damages a lot of systems. I said earlier about peroxynitrite inhibiting L-tryptophan decarboxylase and hydrolase or hydroxylase. And it turns out that the reactive oxygen species, or the superoxygen molecule that's produced by the mitochondria, connects with nitric oxide and steals nitric oxide from the blood vessels and the cells, and creates peroxynitrite. And peroxynitrite is associated with Parkinson's disease. It's associated with cognitive impairment because of the damaged neurotransmitter deficiencies. enzyme deficiencies, neuroreceptors are damaged, and you cannot make the epinephrine, norepinephrine, dopamine, serotonin, NMDA. You can't make these neurotransmitters when you have an inflammatory environment. So it's about addressing the inflammatory environment that comes from pure stress and physical damage. So as they say, all roads lead to Rome.
Yeah, absolutely. And so with this inflammatory process, how do you test for it? How do you see it? Is there something tangible, or are you diagnosing it on history?
No.
On, you know?
Well, a great question. You can assume it's there by just listening to the patient, where they've had subconcussive, multiple subconcussive, heading the ball, American football players tackled, rugby players, hockey players with checking, MMA, boxers, all these contact sports are prone towards the initiation of inflammation in the brain. But if you want to be scientific, there are certain chemicals that you can test, and you can use what are called cytokines. The most common inflammatory, pro-inflammatory cytokines you can test with a blood test is the interleukin 1, 1B, 6, and tumor necrosis factor alpha. But the problem with those is that they're made throughout the entire body. So the question is, when you have a level that's elevated, where's it coming from? You have to assume it's coming from the brain. So what we do in our practice is we know that inflammation or head trauma alters certain patterns of hormones in the brain, from growth hormone, which is the most important one, that is, in the 4 key hormones: growth hormone, testosterone, estrogen, thyroid, and cortisol. Growth hormone is the most common hormone to be reduced from trauma, then testosterone, estradiol, and then thyroid, and then cortisol.
Okay. And so thinking about the reason for that, I guess you mentioned earlier, particularly with traumatic brain injuries and things, I suppose thinking anatomically, obviously, the pituitary sitting in its tiny little bony box, and actually and so I'm guessing, is this the reason that you're thinking?
No, absolutely not. Absolutely not. This is a misdirection that we've been following for many decades. We assume that the trauma is to the pituitary directly, but it isn't. The real issue, and it came out in the literature in 2013, what they found is when you have inflammation for whatever causation, you've got inflammation in the brain, you shut off the area of the brain called the hypothalamus that is responsible for making a hormone called gonadotropic releasing hormone that goes to the pituitary and turns on the production of luteinizing hormone, which leads to the starting of the steroidogenic cascade, which is pregnenolone, progesterone, allopregnanolone, cortisol, and the other pathway, DHEA, testosterone, estradiol, estrone, estriol. All that is damaged, is shut down, as well as follicle stimulating hormone, which turns on ova maturation for women and turns on sperm production in Sertoli cells of the testes. So what happens is we lose the trigger, and it turns out they found that inflammation causes a cell in the brain called the astrocytes to stop producing a signal to the hypothalamus, which is called PGE2, prostaglandin E2. It's necessary to produce PGE2 to turn on the hypothalamus production of gonadotropic releasing hormone. So it's a little intricate pathway, but it's the cause for why we're seeing so many people with not only testosterone estradiol deficiency, but also infertility. And one of the things that is also driving it, it turns out that the spike protein from the COVID-19, that it creates inflammation in the brain. Well, it creates inflammation throughout the entire body. But when it's involving the brain, you get a shutdown. And there are many, many articles talking about the infertility. But if you follow the pathway So coming back to the issue with the pituitary, only in severe head trauma or moderate to severe head trauma will you see anything relative to the pituitary. So the question is, why is it that we have in 85% of the people who have been knocked to the ground unconscious, when they have a CT scan and MRI scan, they're normal? Pituitary is normal, no contusion, no subdural hematoma, no hematomas, nothing. And how come they develop all these psychiatric conditions? That's the theory for PTSD. It's not because they were exposed to a emotional trauma. It's the fact that their brain chemistry has been altered by this inflammatory environment or milieu that develops. That's the real problem.
So we've been looking sort of radiological evidence and sort of imaging, when it's not necessarily going to be. That's what we need to be looking at, thinking chemistry rather than imaging. Okay.
Yeah, I'm waiting for an invitation to Grenada, Spain. There are two doctors that have developed a PET scan, which is a positive emission tomography neuroradiological study, where they can identify the immune cells, the microglia, as being on or off, so that if they're on, that's where they're activated and they're dumping all these pro-inflammatory cytokines. So what you'll be able to do is to test out treatments, and you'll test out treatments that help to quiet down the microglia so that they're not dumping all these inflammatory cytokines. It's brilliant. I found out about them 2 years ago, and they're not ready for outsiders to come in and take a look at it, but it's in Grenada, Spain. So
that could have a real impact on the ability to test treatment, I suppose, wouldn't it?
Correct. Correct. So
you weren't being incredibly controversial by sort of your non-belief, so to speak, in PTSD. It's not the PTSD and the symptoms that you don't believe in. It's the mechanism behind the symptoms.
Correct. Now, we like labeling things: depression, anxiety, bipolar, obsessive compulsive, PTSD, PTS, TBI. We like labeling things. I try to stay away from the labels and look at the biochemistry, look at the molecular chemistry, and say, no, this is a tryptophan conversion problem, or no, this is a neurotransmitter deficiency, problem, which is creating up above in the superficial realm that we tend to stay in, what we call depression or what we call PTSD. Those who are so ingrained in PTSD, don't know about fractalk. And I had a major player in the PTSD world in the United States who called, and we had a beautiful conversation. And when I told the individual that I'm a New Yorker, I shoot straight, I don't believe in PTSD, the phone went dead. Okay. And then they came back and said, why don't I believe in PTSD? I asked a very simple question. I said, tell me everything you know about fractalkine. And they said, fractalkine. I said, yes. What do you know about fractalkine? They said, absolutely nothing. And I said, that's the reason why you believe in PTSD. But if you again go back into the definition of PTSD, it's pure psychological. And they never ask about trauma prior to. Last year, March, did a new article for a presentation to the Department of Health and Human Services in the United States. And I compared the PTSD to TBI in our military, in our patient population. Sent out a request for entry into this program. It was random. 79 people out of 240 responded within the 72 hours that they were given. And the end result was there was a group of people with pure TBI, and then there was a group that were labeled by the Veterans Administration as having PTSD. When I looked at the PTSD people, I asked a simple question. Have you had a traumatic brain injury prior to your diet? And every single one had a TBI, but it wasn't the point of focus. So the question is, what for me is PTSD? PTSD was a missed opportunity to treat a TBI. And in countries like the United States, you can have the criteria for being called TBI, where you have some sensorial memory issues, sensorial. You don't have to be knocked unconscious, Glasgow score of 13 to 15. But in places like the Australia, in order for you to be called mild TBI, you have to have loss of consciousness.
Right.
So the interpretation of what is totally different, but it doesn't matter. Any kind of head trauma, mechanical transduction, you've got inflammation.
So you just mentioned, Mark, that you said, PTSD is a missed opportunity to manage a TBI then. So when you say missed opportunity, does that mean, can you do anything at that stage when they've gained their PTSD label? Right. So tell us about that.
I have a 93-year-old Korean War veteran with dementia. Now, dementia, Alzheimer's, Parkinson's, ALS, MS, those are all inflammatory neurodegenerative diseases. They can be reversed, okay? So what happened was Edward was referred to me through his son, Kerry, who is Special Forces. He has a charitable organization to help other veterans, and he and I work together on his project, and he sends cases to us. And he called me. He said, my father, is suffering with dementia. Is there anything we can do? And I said, absolutely. So I sent him a kit, and he took the kit, and 70 days later, I get a email saying that my dad's dementia is almost gone. I said, good. Let's get onto a Skype. Let's get onto a Skype call. Yeah, he's 93. Okay. So he's been developing this for 3 years overtly, but he probably had earlier symptoms, but he says when he got to 90 is when it started happening. So what happened was I got on a Skype call and I put Edward through the MMSE, which is a testing for Alzheimer's and so forth. He passed it, no problem. We had a lovely 40-minute conversation. He has a PhD in young child development. And then at 90 days, the son sends me a 1.5-minute video of his father talking about his regeneration, his memory. He's no longer needing to write things down. He's not losing his keys anymore. And that's at 90 days. At 180 days, I get another short video where he's on camera with a host of a program, and he's dialoguing like, a young kid. His word skills, word acquisition, sentence structure, his poise when he was delivering it was just beautiful, absolutely beautiful. So in 180 days, his dementia's fully gone. He's not writing things down. He's going to the store and buying things without having his usual notes that he would take. So this tells us that you can recover from the traumas he's had for, 90 years. He's 93, he's now 94. So we're able to recover that. We had Mona from Arkansas, who 32 years after her head trauma, she was on a whole bunch of medication. Within 6 months, she's off all her medications. She ends up going back to school. She was going to school at 18. She got into a bad auto accident, airlifted to a hospital, stroke, whatever, and on a multitude of medications. And within that 90 to 180 day period of time, she's off all her medications. She ends up going back to school. She's now 54 years of age. She ends up going back to school and getting her degree that she started to get when she was 18. First day of school, she gets into the accident. So it taught me it doesn't matter about time. What it matters about is stopping the process and reversing it.
So, I mean, that was an interesting comment you mentioned about the chap with dementia, and I don't know what type of dementia he had, but was very much, it was very much it's treatable, and that again is all based from the cause of neuroinflammation again. What about conditions? I know certainly with Alzheimer's, for example, there's very much a genetic predisposition. I think there's E4 variants. And so presumably, is that genetic predisposition for the formation of the amyloid plaques, or is that for the formation of inflammation, or are you more prone to inflammation? What's your belief around that, Mark?
Yeah, well, I have a separate lecture. It's online about a hormone approach to Alzheimer's disease. Alzheimer's disease genetically, the EPO gene is only in 45% of the cases that they find with Alzheimer's disease. Now, my belief is that, based upon the science that's out there already, is that trauma increases inflammation, and inflammation causes something called hyperphosphorylation of tau protein. What that means is that under an inflammatory milieu, the protein called tau, which is like what holds together the microtubules that run through neurons to deliver the neurotransmitters from one end to the other, that it's disrupted because hyperphosphorylation causes the tau protein to separate from microtubulin A and B. And that is what leads to development of inflammation that begets the beta amyloid or amyloid beta, which is the hallmark. And if you look at a study by the NFL, where they found that if a football player, American football player, had one concussion on the field, that he was 19 times at greater risk than the general population of developing Alzheimer's disease at a younger age, 30 to 49 years of age. Okay? So inflammation, trauma predisposes. And there are some studies going on where they're looking at the history now of people with Alzheimer's to find out if they've had traumas, car accidents, slip and falls, assaults, last wave from being in the theater of war. And then I just did a presentation on Parkinson's, and they're in the general realm of Parkinson's disease. The average age of onset is 65 years of age. And people with head trauma, like veterans and football players and boxers, it is less than 50. So it's a 15-year earlier onset, if not earlier, 40, 30s. So they call it dementia pugilistica, which is the Parkinson's disease that is commonly seen in pugilists, in boxers. Okay. So, that is
additional time then. So I guess, so if you were to be talking to somebody who was aware that they'd had multiple traumatic brain injuries or sort of the subconcussive injuries that we were discussing earlier, so what would you be suggesting to them? Well, the first thing we do is to prove that the inflammation is participant in their process. You can do, we have a 28-point biomarker panel. It took me about 14 years to perfect, which looks at the pattern of hormones in the brain that are influenced by trauma. And they're all substantiated by, literature. The scientific literature talks about, these factors. And you can also add to it the cytokines. I said the cytokines because they're produced all over the body, the gut, fracture of the bones, and so forth, that they're not specific for the brain, but you can still do the level and see that it is elevated. And when you treat it, the marker should be that they lower down. And a few years ago, we did a trial, a pilot study in our military, where they came in and as part of their 28-point biomarker, we added 2 of the pro-inflammatory cytokines, interleukin-6 and tumor necrosis factor alpha. When they were elevated, we didn't know where they were coming from, the brain, the butt, the bones, the wherever, the gut. When they were elevated and they were put on treatment for, our entire protocol based upon the lab results, and the level of cytokines dropped, they got better. Every single one of them got better by dropping the cytokine. And if you start looking at just the world of cytokines, we know in autoimmune diseases like rheumatoid arthritis, lupus erythematosus, Crohn's disease, scleroderma, all these autoimmune diseases, Hashimoto's thyroiditis, they generate a lot of cytokines. These cytokines go into the brain and turn on the inflammatory mechanisms in the brain by activating the microglia.
And we know this is a fact because when studies were done looking at depression in people with autoimmune disease, we'll talk about psoriatic arthritis, and they put them on a medication which blocks the interleukin 6. What happened was their peripheral psoriatic arthritis symptoms improved and their depression disappeared. And when you looked at the comorbidity, the association of having the psoriatic arthritis, there's a 60 to 90% concurrence or occurrence of depression. And that depression disappears when you treat them for the psoriatic arthritis, which means you're treating them for the elevation in an inflammatory cytokines, which tells us that the inflammatory cytokines, when they get into the brain, they create the mood disorders. And this is what we see in all our patients. So what do we do with these patients? Well, we first run them through our biomarker panel, 28 biomarkers. We have a software package that analyzes it because as humans, there's so much depth to correlation between growth hormone influencing prolactin, which influences luteinizing hormone, which influences estrogen and testosterone production. You've got growth hormone that influences T4, T3. So we as humans, cannot hold on to 5-6 layers of interaction. The software has it. The software will interact. Also, certain medication influences the laboratory results. So a common medication like Wellbutrin, which is bupropion, Wellbutrin for depression, it increases growth hormone, which leads to an increase in prolactin, which leads to an increase in decrease in luteinizing hormone, and you can't make your hormones.
Yeah. And so how about other medications, sort of pain relief medications, opiates and things like that?
Narcotics, all the opioids, all the narcotics are horrible for dropping luteinizing hormone. A medication called gabapentin. If you're on gabapentin, I don't take you as a patient because gabapentin destroys one of the most important pathways, which is the pregnenolone, allopregnanolone, progesterone, pregnanediol pathway, which is important for anti-anxiety, anti-depression, great sleep, or you get insomnia if you don't have enough of pregnenolone, progesterone, and allopregnanolone. Allopregnanolone in the States came out as a pharmaceutical drug called brexanolone 7 years ago. 7 years ago. So they know it's an important component, but it's $34,000 a year for this medication when we have a product which is $80 a year.
Yeah, and that's amazing, isn't it? So also, I mean, I knew we were going to end up doing this, market. When I was sort of doing a bit of research and reading some of your papers, I kind of realized that we were going to bombast all over the place, but I'm enjoying the journey at the moment, so if it's okay. Thinking about this, especially, I guess, for people who have had, I'm thinking about our veteran community again. Often they'll have significant polypharmacy after this, and they'll be treated with pain medications. And another area of medicine that I'm really passionate about is actually in the field of addiction medicine. And unfortunately, our guys and girls who sign up and enlist in the military and who sometimes have been medically discharged afterwards can go from this wonderful tribal environment to a really traumatic event, a physically traumatic, emotionally traumatic event, and then essentially be left with intractable pain for which they get given pain medications that can kind of almost in the short term feel like they're anesthetizing some of the problem and that they are making them feel better, but actually then they get left with addictions and things. So now they've had a emotionally traumatic event, a physically traumatic event, they've got this brain inflammation now, and they're now dependent on drugs. And I'm guessing that those is particularly with not only the opiates, but even some of the antidepressants that can be really sort of causing further neural injury, I'm guessing. Am I right here then?
Well, in our American Physician Desk reference, it has for all the SSRIs and a lot of the other forms of antidepressants, it has black box warnings that upon initial use can increase the occurrence of depression and increase the occurrence of suicide. So I have a close friend, John Spagnola, who is writing guidelines for Department of Defense for making sure that every prescription of a SSRI or antipsychotic medication that comes with instructions and specific dialogue and signing a document stating these risk factors, because in the past they weren't. So we have a lot of people that are getting, committing suicide, 44 a day here in the United States. And part of the problem is that the doctors are trying to do their very best with the medication that we have, but what does the medication do? It masks the symptoms. And when you get to a certain level of polypharmacy, you totally shut down your emotions. So your self-empathy goes. And if you don't have empathy for yourself, it's easy to commit suicide. It's easy to say, okay, I have no value. I don't care about myself. No one cares about me. Let me just get rid of it, get rid of myself. So that's part of what happens. And in fact, in one of our C-SPANs, which is the congressional television program where they record, meetings in Congress, there was a meeting some years ago, 5 years ago, 6 years ago, where the congressional members were asking the military medicine, why is it that in the military there is a 50% greater occurrence of suicide in the military than in the general civilian population? And the difference is the polypharmacy, what they're using, the incredible amount. Now, our patients get off of all their medication with their primary doctor. I don't stop their medication, but they find they don't need it because medications, whether or not they're addictive medications like the narcotics, the Valium-based, the benzodiazepines, the opioids, these are addictive in and of themselves, and I'll talk a little bit about them and some of the science, as well as the things like the SSRIs become addictive because they alter the chemistry of the body. So you got to take them off it. And one of the things that I've been seeing, the ploys or the patterns I've been seeing in our Veterans Administration is that they take people off their drugs too fast. So what happens? They get withdrawal symptoms and the doctor says, you just need to be on the medication. It's a slow process relative to how long they've been on it, what they've been on, and you've got to take them off of one. It might take 6 months every drug to get off of their system, depending upon how long they've been on. Talking about neuropathic pain is what you brought up, and narcotics. Let me go to one other area first. The brain is incredible. When you are suffering, the brain says, look find something to make me feel better. So people go first things first, alcohol. Then alcohol works to a level, and then they go street drugs. And if they're in the VA or in their medical circuit, they'll go and tell the doctor, well, I've got pain here, I've got this there, because they're trying to get some drug to make the brain feel better. Instead of fixing why it's not doing well. And the reason why it's not doing well is because the loss of neurosteroids in the brain. What are neurosteroids? Neurosteroids are the hormones produced by the cells of our brain. The neurons, the oligodendrocytes, the astrocytes, they all produce hormones. What kind of hormones? Testosterone, estradiol, progesterone, pregnenolone, allopregnenolone, pregnanediol, DHEA, thyroid from the astrocytes, T3 from the astrocytes. So if there is an environment that is called a neuropermissive environment, where it allows the neurons to function to their optimal, they're kicking out all these important hormones that help to keep the brain functioning optimally, neurosteroids. Below the neck are the neuroactive steroids that are produced by, the ovaries, thecal cells, or the testes, Leydig cells, or by the adrenals, or by the thyroid, or the liver with all the growth factors. That growth hormone stimulates the liver to make 9 proteins that are in the growth hormone family. And those, some of them can get into the brain, not all of them. Therefore, you need to make them in the brain. And all this became apparent in 1982, 83 with Dr. Bailou out of Paris, France. He found that our brain cells had enzymes to convert cholesterol to the first hormone, pregnenolone, called the mother of all hormones. And what causes cholesterol to convert to pregnenolone is a hormone called luteinizing hormone. Luteinizing hormone is shut down from inflammation, as I said earlier, and luteinizing hormone is shut down if you use testosterone, if you use estradiol. So if you're supplementing a patient with testosterone or estradiol, you need to also feed them DHEA and pregnenolone. Otherwise, you wipe out 35 hormones in the brain. And that's because luteinizing hormone is the tip of the spear, and then becomes all these other hormones through steroidogenesis, or this hormone cascade, or this pathway of generating our brain hormones as well as the entire body.
So if say you've started somebody on TRT, they started off with a testosterone deficiency, and as you say, Mark, they the next test that you'll do, you might check to see, do another blood panel, and you might see that LH and FSH, for example, would be completely almost undetectable. But the patient feels great and they're happy, they've got no symptoms, they're suddenly coming back to themselves. How do you manage that patient? I mean, it sounds like you'd be supplementing that regardless anyway.
Well, no. If in the literature and in our patient population of over 3,000 patients, what happens is within 4 to 6 months of being on strictly testosterone, you start losing the hormones in the brain and you start developing symptoms: agitation, aggression, depression. Patients come back and say to the doc, "Look, I felt great in the beginning. I don't feel as well now." And then what happens is the doctor says, "Okay, increase your testosterone level." And they increase their testosterone level. They feel good for a couple of months, and then they stop feeling well. And we monitor the influence of testosterone on the other hormones. So we know when we're giving injectable testosterone, which we don't do anymore. When we used to give injectable testosterone, we would monitor their luteinizing hormone, their pregnenolone, and their DHEA levels. And what happens is you see them slowly dropping if they're purely on testosterone. So you can take one of two stances. You can be reactive or proactive. In being proactive, we add DHEA 15 to 30 minutes after dinner, either 25 to 50 milligrams for a male or 15 to 25 milligrams for a female. And we add pregnenolone, either 50 to 100 milligrams at 15 to 30 minutes after dinner. That's proactive. And the benefit, if you look at the benefits of DHEA, which I know most countries do not look at the benefits of DHEA. One of the major studies coming out of the Massachusetts male aging study, and they also have it for females, is that if your DHEA levels are low, you have an increased risk of ischemic heart disease, heart attack, and death. You have an increase of inflammation of the lungs, or it's not really inflammation, it's cytokine dumping in the lungs. You have problems with your immune system. You have interleukin-6 and pro-inflammatory cytokines are up. You have poorer wound healing, and you have more irregularity of insulin and glucose. That's below the neck. In the brain, the benefits of DHEA is it increases growth hormone production in males by 10%, females 15 to 20%. In studies that started coming out in 1952 relative to DHEA and major depressive disorder, MDD, showed that it helped to improve it. Also, DHEA stimulates the production of myelin. So in demyelinating diseases, or in the process of aging, we lose the coating of nerves. DHEA stimulates the oligodendrocytes to make more myelin. And in fact, if you look the literature on multiple sclerosis and DHEA, you'll find articles where they use DHEA to help increase the production of myelin. Also, progesterone does that, testosterone does that.
Yeah.
There are a number of things you can use for it. So you can either be proactive or reactive.
So what about the guys who've been on TRT and who'll do a blood panel and then the DHEA, and they've been on it for maybe a good few years and the DHEA is still fine? Because those
I don't see that. I don't see that.
Okay.
And we do a 28-point marker on every patient every year, every 12 months. So we know we have so much data that the computer software is analyzing. So we see patterns that most centers don't see because they don't do a robust enough laboratory testing. The common testing is maybe total testosterone, which is worthless. Free testosterone is the key. And everybody says, oh, my total testosterone's 1,000 or 800. Who cares? What is the active form, right? Yeah. It's like, I travel a lot. So I've got a large bowl where I put the coins into, okay? I'm here in the United States. I go into that bowl. What am I looking for? I'm looking for US coinage that I can use. There's none or very little, okay? It's the same thing what happens with, total testosterone is like a bowl full of a lot of coins. You can't use ones that you need. It's got a lot of junk, DHT is part of that. Epitestosterone, albumin-bound testosterone, sex hormone binding globulin-bound testosterone. Only the 2% free and the albumin-bound are the two that are important. And the bioavailable testosterone is what we should guide ourselves by. And we should be at the 50th to 75th percentile of every range, which brings up the issue that, why people who get hormone testing don't get on hormones is because the physicians ignore the fact that we are individuals and the amount of testosterone that I need is different than this guy's next to me or that guy over there. It's totally different.
Yeah. And I think that's really interesting as well, isn't it? I mean, we have, I don't know how your laboratory normal ranges are. I may where
There's no normal range. There's
exactly.
It's a reference range.
So we get very prescriptive on the results that get sent out. The laboratory will send out a very prescriptive, between X and Y. And the funny thing is that it's postcode lottery. So essentially, somebody in Newcastle's normal range will be different to somebody in Plymouth, just based on what that laboratory has found while they've been auditing their results and things. I think that's one of the things that as a clinician is really challenging to sort of explain and go by, because actually I think certainly in the UK I'm finding that medicine is becoming incredibly formulaic, probably partly due to funding, I guess, maybe. So people want to know.
National Health Service, economics. Yeah.
So exactly. And I think it sort of gets to the stage where you have to practice, you have to follow a flow chart. You're not using your clinical awareness or anything anymore. You're having to decide based on some pre-decided thing that has been decided so it fits in with somebody's budget somewhere. And I think that really makes it quite difficult. But it also means that you can't really treat the patient holistically as well. And sort of take into account all the things that have impacted them and their individuality as well. And like you say, testosterone levels for one guy could be fine, but for another person, it could make them feel quite awful. And I think that's one of the, clinical judgment has to come in. In here, I think that's really important. So all of this said, obviously you've mentioned about this product, and I do want to come back to this, but I think when you were talking earlier about the sort of the triggering of inflammation within the brain from emotional responses to things, can you go at it from the other end then? Can you go at it from the other angle of things? So i.e. management of the emotional response, is that ever enough to be able to reduce some of the inflammation? Can you try and adjust emotional response to it, or would you always have to treat the inflammation directly? And if you are treating the inflammation directly, how are you doing that?
Yeah, well, that's a complex question, therefore a complex answer. Um, if they have emotional issues, um, what they can do is lower their cortisol. 15 minutes of
Mhm.
meditation 3 times a week is a way that you can lower the cortisol. But what you need to do is decide whether or not you're going to take that slow approach or you're going to jump on board with some natural products to help them to
Yeah.
achieve the goal in a shorter period of time. What we do in our treatment, we get the laboratory 28 biomarker panel done, and then we put them on to what the program recommends. The program has predictive treatments as well. So it looks at, analyzes all the lab results and says, okay, based on this, and this, and this, we recommend, or the software recommends these products. So
Mhm.
we'll put them on the DHA, pregnenolone, vitamin D, the zinc. We'll put them on to the natural nutraceutical products. And then if it says
Mhm.
they're deficient in thyroid, we'll look and see if the pattern of their thyroid, we have a 5-point thyroid panel: TSH, free T4, free T3, reverse T3,
Mhm.
reverse T3 ratio. And then we have a new one, a sixth one, which is called the TSH index or the Jostel index. Why that has become very, very important to us is because the Jostel index tells us whether or not the dysregulation of the thyroid is coming from the brain or coming from the thyroid gland in the neck. The TSH index uses the TSH and the
Yeah.
T4 level in a
Right.
computation. It's a
Yeah.
mathematical computation. Dr. Jostel out of Chicago, 15 years ago or so. And it's brilliant because it helps to define who have central thyroid related problems and who have peripheral. Okay.
Yeah. Yeah.
So, yeah. So we we try to correct the hormonal milieu because the interaction of the neuroendocrine system on our neurological system, which is our emotional.
Yeah.
So we have people who are on multiple polypharmacy or are not on medication, but are obviously having challenges with depression, anxiety. We
Yeah.
will jump forward and put them on to whatever is indicated by the testing. And to go
Yeah.
back to the ranges, there's no normal range, there's only reference range. And the problem
Mhm.
is that, let's say, for instance, for this example, the range is between 10 and 90, whatever the hormone is, 10 and 90. If a person comes in at 11, the doctor says, oh, you're within the normal range, you're normal.
Yeah.
And the patient says to him, but doctor, I have depression, I have this, I can't, my libido's gone, I'm angry, I'm emotionally reactive. The doctor says, oh, you're depressed, instead
Yeah.
of fixing the range. So what did we find? We found that if you take the lower number, which is 10, and the higher number for this example, 90, you add them together, 100 divided by 2 is 50. We bring them up towards that 50. It's called the median.
Okay.
So it doesn't
Yeah.
matter what laboratory you're using, you can always figure out where the median is based on that laboratory. And one of the
Yeah.
things that we've learned in the United States with the tens of thousands of laboratories is every laboratory is different ranges. Why? Because their equipment at the location that they're at, with the water that they use, with the laboratory testing, the test kits, and the
Yeah.
machines that they're using are all calibrated differently. So we only use one lab. We don't use
Yeah.
multitude of labs because every lab gives you a different outcome.
Yeah.
So
Okay.
you're constantly going up and down. So you need to find one quality lab and stay with that
Yeah.
quality lab. And what we
Yeah.
have in our software package, it has 3 labs that are included, or 3 labs to be interpreted. So you can see the difference between each lab.
Yeah.
So it's a very important concept that not very many healthcare providers are tuning into because they assume. Now, I'm a medical director of education for
Mhm.
a large specialty clinical lab in Florida. And
Mhm.
They have high-tech, unbelievable high-tech there, better than some of our major big-name laboratories. And I support them because their testing is so phenomenal and consistent.
Yeah, and that's so important. It's interesting, actually. In the UK, we have some big companies where we're getting more. I think people are becoming much more empowered now to check in on their own health and get their own blood testing services done. But actually, I think sometimes what people don't realize is that some of the laboratories that are being used are outsourcing some of it. So actually, they're not necessarily getting the consistency and reporting that they would, the
Right.
branding on their packaging and everything would indicate. So yeah, no, I think that's an important point you've raised there. So for these patients, that we've been talking about now, these guys, the TBI guys with testosterone deficiency, obviously you've mentioned the importance of DHEA and pregnenolone and things. What should these patients be? What should these patients be doing? Where should they be looking? Who should they be reaching out to?
Well, obviously, doctors like yourself that understands the relationship between traumas and hopefully incorporates into your intake forms a history of traumas that they've had, because the question is, how do you account for hormonal deficiency? Do you say it's genetic predisposition? Do you say it's aging? What? And this is what's being missed here in the States. Trauma is probably one of the most clear causations for hormonal deficiencies. And we've got, tons and tons of literature constantly repeating the same narrative that trauma, inflammation, hormonal deficiency, trauma, inflammation, hormone deficiency, inflammation, hormonal deficiency, oh, history of trauma.
Yeah.
So you need, the clients out there need to find healthcare providers that understand this relationship, understands the influence of medication, understands that you need to do a robust laboratory testing, so that think of it as every lab test is a pixel in a picture. The more pixels you have, the clearer the picture is. So if you have a clearer picture of what the problem is, you can treat it more efficiently. That's why we see, I used to still get patients who are evaluated by other doctors with 4 blood tests, testosterone, estradiol, luteinizing hormone, and cortisol. That's it.
Yeah.
What about the thyroid? What about the prolactin? And that's a key factor. If you don't do prolactin, you don't know, especially in traumatic cases. In traumatic cases, you can see elevation in prolactin because you have damage to the hypothalamus, to the area that produces the periventricular nucleus, that produces the prolactin inhibiting factor, PIF. So you get high levels of prolactin, and prolactin shuts down testosterone production. So you look at someone's blood and you see low level of testosterone. So what do? Start them on testosterone? That's what the knee-jerk response is. And you don't know if it's primary, secondary, or tertiary hypogonadism. Is it coming from the gonads, the thecal cells of a female, or the Leydig cells of a male? Is it coming from damage to the pituitary, or is it the hypothalamic level, the third level? Okay.
Yes.
And we define that, because once you define where it's coming from, it answers a lot of questions.
Treatment.
So hypothalamic involvement, pituitary hypothalamic involvement is inflammation. It helps to corroborate your direction, give you more support, until we have this new PET scan that looks at the microglia being turned on, which would be great. Understanding the traditional or the foundation of endocrinology is, if I give you a hormone, it's going to suppress your own body's production of that hormone, starting out in the hypothalamus. So in the process of shutting it down, it just doesn't shut off that one, like testosterone. It just doesn't shut down testosterone. It shuts down all the hormones, because the initiator hormone is luteinizing hormone. That's what gets shut off. Luteinizing hormone gets shut down. And that can cause you also, in the majority, I don't treat what's called high cholesterol levels. I don't believe in it. But high cholesterol levels are almost classically found in people with low testosterone. That's because cholesterol is converted to pregnenolone, then down the pathway and ends up being testosterone or estradiol or pregnenolone or cortisol. So if you shut off cholesterol, you shut down all the pathways,
Downstream.
the entire downstream cascade or steroidogenic pathway. So cholesterol, very, very important. In fact, there was an article I was reading that said that if you had, in the United States, if you had a cholesterol that was less than 220, you were 50% greater risk of developing Alzheimer's disease. And if you look at studies that have been done for decades on Alzheimer's and hormones, you see that in women, estradiol, testosterone being low, higher incidence of Alzheimer's disease. You look at male studies, low testosterone, increased occurrence of Alzheimer's disease. The relationship is there. Part of that reason is because what estradiol and testosterone both do, they upregulate a transport mechanism called neprilysin that takes the beta amyloid out of the cell and gets rid of it.
So
anti-inflammation stops the production of tau protein fragments and beta amyloid and tangles and CTE.
So going back to Alzheimer's then, for example, in your patients with Alzheimer's have already formed these plaques. I know there's various trials on at the moment, I think trialing donanemab, I believe, in the removal of plaque. But what's interesting is that they're not finding necessarily a direct correlation between the removal of plaque and the symptoms from those patients. Do you think that's because the inflammation remains?
Correct. And the reason is that the tau protein, the beta amyloid, the tangles, all that stuff creates inflammation. And we've heard of type 3 diabetes. What is type 3 diabetes? That's Alzheimer's disease now, their new terminology, type 3 diabetes. What's happening there? Because of the inflammation, you lose things like growth hormone IGF-1. And as we get older, we lose growth hormone IGF-1. The benefit of IGF-1, insulin-like growth factor, generated in the liver under the direction of growth hormone and estradiol, what happens is you lose the insulin-like effect of insulin-like growth factor 1. What does it do? Increases by 10% the sugar transport into neurons. So if you lose the ability of getting sugar into the neurons, they die. That's why they're calling it type 3 diabetes. So inflammation shuts down these pathways that allow the feeding of the neurons. Astrocytes, when astrocytes are activated, they stop feeding transport of glucose to the neurons. So you're actually starving the neurons. And what happens? The mitochondria go into overdrive and produce free radicals. Those free radicals create more inflammation. So it's a catch-22.
Yeah.
So
I mean, I suppose so with regards to the treatment for somebody in that situation, the treatment that I know that you offer through your Millennium Health Centers, that could be the same treatment or similar treatment to what you'd offer somebody with inflammation caused by either injury or stress.
Alzheimer's disease, as I gave an example from the NFL study, where they found that contusions, concussions are 19 times greater risk of developing Alzheimer's at a younger age, tells us the relationship between trauma and the onset of Alzheimer's disease. Absolutely. And it's in between is inflammation, trauma, whatever, inflammation. If it is genetic Alzheimer's, you generate the beta amyloid, which is beta amyloid, which is a whole new issue in and of itself. There are two forms of amyloid. There's the alpha amyloid, which is inert, and a beta amyloid, which is associated with Alzheimer's disease. The alpha amyloid is neutral, doesn't do anything, doesn't create any inflammation. So the question is, why is it that our body preferences the development of beta amyloid? Well, it turns out there are three enzymes. and there's a protein that they call APP, which is Alzheimer's precursor protein. That protein can be cut in two different patterns. One pattern gives you alpha amyloid, inert, no problem. The other one gives you the beta amyloid, that's the problem. It turns out that the one that gives you alpha amyloid, which is called alpha secretase, is zinc dependent. So if you have zinc deficiency, you're going to default from making alpha amyloid to making beta amyloid. So zinc's a very important aspect, and you can look it up on, zinc and Alzheimer's. Now, 10 years ago, they were talking about aluminium, and its association with Alzheimer's. Well, it turns out that if you're zinc deficient, guess what metal the body absorbs to replace it?
Ah, really?
Aluminium. You're aluminum. Okay? Crazy, huh?
Yeah, and so the zinc quandary can be difficult as well, because I think people have really sort of taken up to engaging with zinc levels and things, but actually even from that point of view, testing for zinc is also not necessarily entirely straightforward because of the different labs testing processes, and the results that you'll get aren't necessarily going to be completely conclusive either. So what do you suggest with regards to people supplementing with zinc?
They need to take an inophore with it, which is what helps the zinc to get into the cell. The most important one that we use is called quercetin. It comes from fruits and it's condensed down into quercetin. I think apple's number one. And what quercetin does is it helps to bring transport zinc into the cell. Having zinc circulating in the blood is wonderful, but it has to get into the cell. The added benefit of zinc in the cell is that it stops the replication of SARS viruses, and it stops the replication of influenza A and B, and it stops the replication of arbovirus and enterovirus. So, I haven't had the flu in 15 years, and I don't get flu vaccines. Okay.
Yeah.
I take zinc, I take quercetin, I take vitamin D. If you look at the literature on vitamin D and COVID, there's 1.32 million articles as of yesterday showing how vitamin D, which is a hormone, D, helps to protect the system from the attack of SARS. So, and it's not 1,000 or 500 international units a day. It's 5,000 to 10,000, 125 micrograms to 250 micrograms. Yeah.
And I think that's, I think a lot of people will think they're supplementing with it. And then actually, from the dose dependence point of view, it's important to look into that as well, isn't it?
Yeah. Well,
fantastic.
There's, the fallacy of vitamin D toxicity. I just sent you a great article about zinc and Alzheimer's disease, talking about how important zinc is to minimize the Alzheimer's. And, it's a good read.
Yeah.
I'll get you a couple other articles sent to you. But there's a lot we can do. A lot we can do.
And I think that's one of the things I was going to say about the articles you've just sent. If I'll put them in the link below the video when I put this out. But also, I think one of the biggest things that I've taken away from today, Mark, and from talking to you is actually this is really hopeful conversation. And I think that's one of the things that you engaging with conversations like this and making such a massive and complex subject so accessible to people is so important, because actually a lot of the people that you're reaching with your treatments and with your consideration of their health are people who medicine have not necessarily done particularly good service to, because again, like you say, we're treating symptoms as opposed to as to the cause. And actually, by treating the symptoms, we're adding polypharmacy, which can sometimes be exactly what makes things even worse and really compounds the issue. So, I think the conversation today has been really educational for me. It's been absolutely fantastic. And I'd like to share the links to some of your publications as well, including the website below as well, for people if they do want to follow up and find out some more about what it is that you talked about today.
Absolutely. I sent the primary access to our educational website. I sent it to you, where your audience can look at some of the science. There's nothing there that's good. It's about selling anything. It's about education, because once you have the power of education, you can then make decisions for yourself that other people that you've entrusted to make decisions haven't a clue about, because they're part of that machinery. And that's why we have a number of your top military who fly in, who have been flying in to get assessed and treated by us, as well as, you know, our treatment protocols are being shipped to the UK. We've got 54, 55 people who are on a treatment protocol. Some people from the sports area, some people from just who have had car accidents or whatever the situation is, who are responding very well. And I can link you to some of those people so you can get their firsthand experience from treatment. So that'll give you support for, you know, what we've been able to accomplish.
Yeah, that's fantastic. Well, thank you so much for your time today. I very much appreciate it, and to discussing this.
My pleasure. So,